And today I would like to talk the opportunities that we have in the personalization of treatment patients with an AMD. So we have these options due to the improvement of diagnostic options, OCT improvement, but on the other hand, new drugs. I think it is not a surprise and it is not a secret. It is not a secret what journey was made by OCT for all these years, for the last 10 years, since the moment we got it. And on this slide, we see the first prototype of optic coherent tomographer, and now it looks completely different. This is one of the first prototypes and one of the first in vivo scans of the retina, and you can easily see that now it's different from the scans that we are using now in the clinical practice. Well, truly, OCT today is much more precise and it has better resolution. It is able to visualize not only retina, but also we can look at vascular compartment, anterior chamber. We can use angio regimen, AS-OCT, AS-OCTA, and biometry. So currently, multimodal OCT is truly multimodal, and it is comprehensive diagnosis. And the more we talk today about optic coherent tomography, the more frequently we heard the word biomarkers. The term biomarker refers to a broad subcategory of medical science that is objective indicators, and most importantly, they could be measured accurately and reproducibly, and OCT is one of the best tools for the assessment of this phenomenon. And for this time, whilst OCT is available, we accumulated many OCT biomarkers, and there is a big variety. So I think there are more than 100 of them, 100 plus. And from this multiplicity, definitely we can make systematization and further classification of all these biomarkers, and these attempts are successfully made. For the last few years, we can at least find several attempts of classification that were published in high-impact factor journals. For example, in 2022, in Retina Today, they tried to systematize OCT biomarkers according to anatomical structures, vitreous fluid, neurosensory retina, microcirculation, RPE, or choroid, or choroidal neovascularizations. Well, intuitively, it is clear, but it doesn't give us much from practice. We fully understand which structure is involved in the process. Well, in parallel to that, there was another attempt to classify biomarkers based on systemic disorders. That's a group of Samantha in Retina Today. So this is something which is called oculomics. That's a recent term to cover different ophthalmic biomarkers that could prove systemic inflammation. This is hypertension, vascular catastrophes, diabetes mellitus, neurological conditions, Alzheimer, multiple sclerosis. And by the way, the accumulation of OCT biomarkers is offered to use the term OCT omics, oculomics and OCT omics, two new terms. But we move on, and there is another interesting classification offered this year by Panda and published in Retina in 2024. And these are OCT biomarkers that were grouped by disorders. So they try to sum up biomarkers that have particular interesting mnemonic characteristics. So these are the ones that we can easily assign particular interesting names. And here are examples: cotton ball, or crack sign, or double layer, or rain cloud sign, or flying saucer. So that could be some, illustrative image which is shown on the scan, and here are the examples associated with different signs or features or phenomena. Well, this approach is attractive, it's easy to remember, but unfortunately this is the way authors managed to cover just 37 biomarkers, which is truly not enough. In our turn, even last year, we offered approach for OCT biomarker systematization that roughly splits these 100 plus biomarkers between universal and specific. So universal are the ones which are typical for the pathologists, frequent pathologists, and this is vascular, exudative, neurodegenerative, RPE degenerative, etc. And there are specific ones which are related to specific diseases or minor groups of the diseases. Well, in particular, age-related macular degeneration and retinal toxicities, and they are more for differential diagnosis. And universal are very good for the prognosis, for prediction, because they reflect particular injuries or defects that influence specifically the outcomes of treatment of the patients. And today, having options to treat different pathological pathways in NMAD, we can personalize the pathways for our patients, because this is multi-component disease. It's inflammation, it's fibrosis, this is pachychorioid component. So selecting patients with particular domination of one of these components, we could more selectively and precisely treat our patients. And actually something similar could be seen in the diabetic macular edema treatment, where you see inflammatory component is very strong. And for some patients, we select intravitreal steroids as a primary treatment due to the activity of the inflammatory component. And today, for the patients with neovascular AMD, we have a good tool to work not only with anti-VEGF via working with a signaling pathway angiopoietin. I'm speaking about faricimab. It's intensively used for neovascular NMD treatment. These are the characteristics which help us to personalize the treatment of these patients. One of the important factors of the activity here, fibrotic activity, that can effectively be controlled by this drug. And we have to select the patients where the dominating vector of fibrotic activity in using OCT, and they are reflecting the vector of fibrotic activity. This is blood or detachment of epithelium. And if we give cumulative characteristic here, that's mainly subretinal hyperreflective phenomenon. And here on the slide, you see the example of accumulation of lots of subretinal fibrin in patients with neovascular NMD. And regardless timely and intensive anti-angiogenic treatment, unfortunately, still we appreciate subretinal fibrosis and non-adequate functional outcome. The other important aspect of these biomarkers that are reflecting fibrotic risks are definitely subretinal bleeds. And we see that hemorrhagic components and hyperreflective phenomenon and fibrin itself and subretinal fibrosis, well, all these are reasons of subretinal fibrosis. And it's a main reason of severe and unfortunately irreversible loss of visual acuity in patients with NMAD, regardless of the ongoing anti-angiogenic treatment. And speaking more about fibrotic story, I want to have common understanding with you. It's not always bad when we speak about fibrin and subretinal bleed. That's negative outcome. But if we look at another option of fibrosis, which is sub-RPE fibrosis, so that could be quite optimal outcome. We can see some positive side of the story, because here it is represented by mature vessels, which are created based on adequate anti-angiogenic treatment. And in case if we manage to create such fibrovascular pillow under the central macula, then we hope for a rather good functional outcome, and most over stable if we continue adequate control of exudation activity in this area. And for example, this patient is supporting visual acuity at the level of 0.4 already for quite a time. exactly due to this fibrovascular detachment, which is seen frequently among patients with neovascular AMD, and it's important. It's important to have some tool in our hands that is working in fibrotic vector and is able to control the development of all this fibrovascular detachment and to seize the uncontrollable proliferation. And by the way, another example of how the signaling pathway of angiopoietin 2 allows to control fibrotic proliferation is shown here. These are patients with diabetic molecular edema, where faricimab reduces the risk of epiretinal fibrosis. Well, speaking about inflammatory biomarkers, important features are intraretinal hyperrefractive cysts and epiretinal fibrosis, hard exudates, and intraretinal hyperreflective foci. And they're seen not only patients with neovascular NMD, but with other pathologies like diabetes or retinal venous occlusions. And very frequently, speaking about the activity of inflammation, we hear within OCT phenomenon, we hear about so-called intraretinal hyperreflective foci, and they, as it is believed, reflect the activated macrophages. So these are minor inclusions without tracks, harbor transmissions, without shadows behind, as you can appreciate here. But here we need to be cautious and not to miss them with initial depots of hard exudates that is in the chain from hyperreflective cysts, then foci of the larger diameter, and finally it's hard exudates depot. So this chain, hyperreflective chain, in fact is related with the activity of inflammation, because if we appreciate the concentration of pro-inflammatory cytokine IL-8 or cell adhesion molecules in the eyes of the patients with infraretinal hyperreflective foci, we'll see very high concentration, which confirms the link of hyperreflective phenomenon with the activity of the intraocular inflammation. What is interesting to say that hard exudate by itself is correlated with the high activity of pro-inflammatory molecules, as it was shown in one of the prospective studies in inflammatory biomarkers and the risk of diabetic retinopathy. And we can appreciate here that definitely with inflammation, the vascular permeability is deteriorated, and it is the reason of intensive exudation of not only cirrhotic but also lipid components. So speaking about the features of inflammation, we should always remember that even such simple phenomenon like solid exudate, in fact, indirectly related with the activity of inflammatory components. And coming back to faricimab, we have a good tool today, fantastic tool to control the process. And registrational studies also showed that the use of this treatment, let's say in patients with diabetic molecular edema related not only with the suppression of exudative component, but with active regression of retinal hyperreflective phenomenon and hyperreflective foci. So another class which is extremely important in the vascular NMD, so these are biomarkers for pachychoroid spectrum disease activity, which is choroidal thickness, choroidal vascular index, intervortex anastomosis, and polyps, and we'll talk about it in detail in a minute. And the importance of this class is the following. When we speak about pachychoroid spectrum diseases, we should always keep in mind that in these patients, especially if it is central cirrhosis situation next SNV, it would be dual exudation mechanism where fluid comes not only with choroidal neovascularization, but also from the vascular envelope, as we see it in patients with non-complicated central cirrhosis phenomenon. And to understand which component is dominated, leakage of the CNV leakage is not possible, neither by OCT or angio with contrast, no way. So we should hope and we should rely on measures that suppress both sources, RPE damage and CNV. Speaking about biomarkers, I have to say that pachychoroid is when we see polyps, a very thick vascular wall, and if we measure it subfoveally in 3 consecutive measurements, and we use the median of 3. But here again, we need to be cautious, as the normal thickness of the vascular wall is quite variable, and mainly it depends on 2 parameters, age and axial length. So please don't think that all this thick vascular wall is definitively pathological, not at all. So we should keep in mind axial length and age, it matters. But in order to try somehow to minimize these associations, we can also refer to other indexes, specifically to the PCV and CSCR as a venous overload, because it matters. And also what is important is AMD and RPD, because if it's a thickened envelope of tachychoroid phenotype. And another recent biomarker, so-called intervortex anastomosis, very interesting. So these are exactly the pachy vessels that we can appreciate in the vascular wall. And these are intervortex anastomosis, which is combining varicose veins and appearance of this anastomosis. It reflects the deterioration and to a certain extent hemodynamical changes and the appearance with conversion towards pachychoroid spectrum. Why it is important to remember about intervortex anastomosis? Because today we get more and more confirmations because we see that signaling pathway of angiopoietin is very important for the development and for the remodeling of microcirculation of vascular wall, for the development of varicose veins, and possibly for the formation of intervortex anastomosis. And truly, if we get away from fundamental studies to clinical studies, we can appreciate that recent publications are telling us that targeting the Tie2 receptor with faricimab in central serous chorioretinopathy could give us very positive outcomes. And to decrease macular thickness, it was observed in 14 out of 16 eyes. So that's very fresh publication, American Journal of Ophthalmology. So the authors showed very high percentage of patients with the decrease of amount of fluid and complete regression of subretinal fluid with the help of intravitreal treatment with faricimab. So wrapping up, modern OCT allows analyze very big spectrum of biomarkers and posterior segment disorders. If we speak about neovascular in AMD, there are a big group of biomarkers of fibrotic activity, including CGM, vascular biomarkers, inflammatory biomarkers, and also pointing pachychoroid phenotype. And based on that, we can potentially have targeted treatment for patients with this type of diseases. And for that, we have fantastic option of pharmacotherapy as faricimab that influencing not only VEGF signaling pathway, but also angiopoietin signaling pathway, which is controlling fibrosis and inflammation. And with that, I thank you very much for your attention.